Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 39th virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I am a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Understanding Herniated Discs, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it once it is posted on either the IBJI or NSYMCA websites. Many of you here tonight have likely been told that you have a herniated, bulging, slipped, or ruptured disc in your spine. Did you know that those terms are basically interchangeable? Spinal disc problems can occur in any part of the spine, but herniated discs are most often found in the lower back and are the most common causes of lower back pain and resulting leg pain, also called sciatica. I am pleased to introduce Jonathan Erulkar, MD, an Illinois Bone and Joint Institute board-certified orthopedic surgeon with fellowship training in spine surgery, who will go into detail about disc herniation this evening to teach us about the causes, symptoms, diagnosis, and treatment options for disc-related back pain. Dr. Erulkar is a board-certified orthopedic surgeon who specializes in non-operative and operative management of neck, upper back, and lower back conditions, disorders, fractures, and more in both adult and pediatric patients. He completed a combined spine surgery fellowship at the New England Baptist Hospital in Boston, where he assisted and trained with a leading team of orthopedic spine surgeons and neurosurgeons, thus giving him a deeper appreciation for the two disciplines as they relate to spine care. He is experienced in performing microdiscectomy, laminectomy, spinal fusion, and instrumentation surgeries. In many cases, he performs these surgeries using minimally invasive techniques, which can reduce post-operative strain on the patient and minimize recovery times. Dr. Erulkar has also performed a series of Mobi-C cervical disc replacements and is happy to offer this procedure as an option to his patients. In providing care, Dr. Erulkar takes the time to really talk with his patients and tailors his treatments to each individual by correlating and considering their medical history, a physical examination, diagnostic imaging, and their work and social circumstances. According to one of his patients in one of the many 5-star reviews that I read about Dr. Erulkar, the patient wrote, "It's hard to find many surgeons who want to care about the whole you. It's hard to find surgeons who really take the time to listen to your needs and conditions and explain the procedures and possible outcomes in an understanding way. But Dr. Erulkar is just that kind of surgeon, and I am exceptionally grateful for all that he has done to alleviate my pain and discomfort." Dr. Erulkar has 3 children and learned about IBJI through his wife, who is a nurse practitioner and was an IBJI patient herself when she was a tennis player for Lake Forest High School and Boston College. During Dr. Erulkar's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. And in fact, he told me that he really likes the dialogue and the back and forth, so he's going to leave plenty of time for questions tonight. What you'll do is simply type your questions into the question section on your screen, and I will receive them and relay them to Dr. Erulkar immediately following his presentation. I do ask that you please keep your questions general, as Dr. Erulkar will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Dr. Erulkar via one of the options that will be listed right now, and then again on the slide during the Q&A portion at the end of his presentation. One last thing before I turn the podium over to Dr. Erulkar, I invite you to mark your calendar for our next 2 IBJI and YMCA Education Series programs. The first, on Tuesday, May 23rd at 7 p.m., Dr. Garo Immersion will host Things That Cause Foot and Ankle Pain. And then in June, Dr. Kevin Hayek, his presentation, which will be called Acute and Chronic Knee Pain, that was scheduled for last month, has been rescheduled for Wednesday, June 21st at 7 p.m. Thank you again for joining us tonight. And thank you one more time, Dr. Jonathan Erulkar, for your time and effort in putting together this program to help us learn more about the symptoms, causes, and treatment of herniated discs. Now, Dr. Erulkar, please take it from here.
Karen, thank you so much for that very kind introduction. I really flattered and really appreciate you inviting me. I'm happy to be here, both to you and the YMCA organization, and of course all the attendees for today. You know, understanding disc herniations, is a big topic to say the least, and I think almost everyone at one point or another has had either an issue or a family member with issues related to their discs. So I'd like to try to dispel a lot of the questions and, oh, let me just slide back just a little bit. Sorry about that. About questions, concerns, as Karen brought up, there are a lot of terms that are often thrown out, disc protrusions versus herniations versus bulging discs, slip discs. All of those terms can get a little confusing. On top of that, there are lots of different reasons for back pain or neck pain. The discs happen to be one, and from a surgeon standpoint, probably the most concerning, but there are several other potential pain generators in the back. Because of the audience, I'm going to start pretty generally speaking. I can certainly get more detailed, but I want to keep this as kind of open to questions, and I'll leave it up to the audience to kind of direct detail and how much information people might want. But just an overview of spine anatomy. There are 33 vertebral segments. The spine is made up of 33 different bones, 7 in the cervical spine, 12 in the thoracic, 5 in the lumbar. The sacrum and coccyx fuse in the early years of life and in utero. Ultimately, adults have 26 vertebrae with 24 intervertebral discs, one disc between each of the bones of the spine. In terms of the disc and considering what discs do, they're the primary stabilizer of certainly the anterior column of the spine, and they're the important motion segment, a portion of the motion segment of the spine. So when we think of spinal motion, we think of, first of all, the two bones of the spine, the vertebral bodies, the disc, which sits almost like a tire between those two bones, which you can see here on this cartoon. And then other portions of the spine include the facet joints, it's pronounced facet joints, in the posterior aspect of the spine, which is in the blue circle. There are also ligaments and connective tissue along with the muscles. These make up an individual motion segment, and again, throughout the cervical through lumbar spine. There are variations on the anatomy, but in terms of general anatomy, that's what we keep in mind. Again, in terms of focusing on the discs themselves, it's essentially made of collagen, sort of a soft, spongy material. I would consider it, my analogy is always describing it as a tire. It's got a tough, flexible outer coating called the annulus fibrosus. It's filled, instead of with air, it's filled with a soft gel or collagen gel that's collagen and water called the nucleus propulsus, and that acts as sort of the shock absorber or sponge of the disc. This cartoon also shows the foramen as well as the spinal canal. So each of the bones of the spine has a essentially is a bony ring in the back, which houses either the spinal cord or the nerve roots that go down to various parts of the body. At each level, there are intervertebral foramen where the nerve roots exit and then travel through muscle, soft tissue to arms, legs, as well as other sensory portions of the body. Taking a closer look at the disc itself, as I mentioned, it has the anatomy or structure of a tire. There's, again, it's a collagen-based tissue, but it's actually organized in a very interesting design. Again, very similar to a tire. The outer rim or the annulus, as you can see, will have a cross-hatching of collagen fibers that acts as a very tough outer coating, very flexible but resilient, much like a tire. On the inside, the nucleus propulsus, as I mentioned, sits in the middle. So again, thinking about terms that are often used, we often hear the term disc herniation versus disc bulge. This has come up a lot more frequently now that patients in general have access to their reports. That's through electronic medical records. So oftentimes you'll hear radiologists describing discs in a various fashion. Either they're a normal disc or degenerative changes, which in this cartoon is showing minor tears or a slight loss of height, which is considered degenerative, meaning age-related, not calling the patient a degenerate or your spine a degenerate spine. The disc could be bulging or it could be fully herniated. The major difference between a bulging disc, herniated disc, I would put it this way: it's a little bit like having a tire that's either bulging versus a tire that has ruptured, and some of the air, or in this case, the gel, has escaped. So a bulging or protruding disc, we would consider the annulus intact, versus a herniated disc in which there's a rupture and then, sort of like a jelly donut, some of that gel has popped out. It is, for the most part, we considered there are separate entities, but from a clinician standpoint and a surgeon standpoint, we consider them more radiologically significant. But in terms of symptoms, they both can be just as symptomatic or asymptomatic, which I think a lot of patients wonder about or question. So on a report, you may have a series of bulging discs or degenerative discs or even herniated discs that may be relatively asymptomatic. So it's a really, we'll get to it in a little bit, but not necessarily something to be worried about if you do see that on a report. Again, in terms of talking about types of disc herniations, the difference between a bulge versus a protrusion versus a herniation, I think this cartoon is a pretty good one in terms of understanding. This is seeing the disc in cross-section. These are the nerve roots that are going down the canal, and then a right and left nerve root that's exiting at that level. So a bulging disc, you would see an intact annulus bulging into, in this case, into the canal. You can have a protrusion where the annular fibers are disrupting or tearing, and then all the way extending to a disc herniation. There are even terms that are used, such as you may hear the term sequestered. That's where a portion of the disc material is actually extruded out and separated from the rest of the disc. Again, from a clinician standpoint, even a patient standpoint, the biggest concern are symptoms and how you might be affected. So a question that often comes up, which you may have, is that a herniation can occur in actually a 360 degree, anywhere along the radius of the disc. But it is really, from a clinical standpoint, significant if it compresses one of the nerves that sits in the posterior aspect of the spine. And that's usually when we see most of our patients. Often I get the question from patients, what could have caused it, a disc herniation, or how did I get this? There are pretty clear associations with risk factors. Commonly, genetics is a strong risk factor. So we do find that a lot of patients that have had needed surgery also have parents or family members that may have needed surgery or have had disc problems in the past. There are genetic clusters of folks like that. Aging, the amount of, how much use and how much wear and tear you put into your body. Understandably, that can, going with that tire analogy, can affect the integrity of your discs. Smoking, tobacco in particular, has been closely associated with disc-related issues, degenerative disc disease, disc herniations. The leading theory on that is that it affects the blood supply to the discs. It also can affect collagen structure. So, for instance, we'll see a smoker whose skin changes are very classic for people that have smoked chronically. Those are actually, if you look under a microscope, their skin, their collagen has changed structurally. We assume that and again, we see similar changes within the discs. Obesity certainly is a contributing factor. Not just obesity or weight unto itself. I also talk to patients about where the distribution of weight is. So unfortunately, a lot of people, but certainly guys, we tend to deposit fat in and around our bellies. So again, like the cardiologist, we get very focused on centripetal weight, or your belt size, actually, is what I often tell patients is more of a concern to me than your actual weight. But for a variety of reasons, that's obviously a big issue. Generally speaking, unexpected forces on the discs tend to be inciting factors. So people often question, when could I have gotten this? How could I have gotten this? Most commonly, it's actually rarely seen in a scenario like this in the middle of the screen where someone's at the gym, in part because that person has warmed up, is ready for the potential load that will come onto their spine. I much more frequently hear people saying they had a coughing spell or a sneezing spell, or were in a rush, weren't thinking about it. They were at Costco, throwing water bottles into their trunk, laundry baskets. That's a very, very common scenario. I've heard as simple as getting off the toilet, and a good number of patients just wake up with some pain that just, again, escalates versus just resolving after a few hours. Inactivity, certainly, I think most people would point to that, again, sort of loosely associated with obesity, but also compromised core strength. We often forget about, changes in our bodies and life over time and how that might affect our core strength. The scenario I think of most commonly is childbirth, and certainly after childbirth, whether it's by a natural delivery versus C-section, just a very, change in someone's anatomy or body will have significant effects on core strength. So again, those are things to think about in terms of scenarios. And then, of course, our lifestyles now, I think more than anything else, are contributing to a lot of disc-related issues that I see in the office, be it working on computers, like we are right now. We're all on a webinar, seated for extended periods of time. People are on phones, on the train, or even at dinner time, like we see in this picture below, where people's necks are flexed for extended periods of time, again, can put strain on the discs, being in the flex position, as well as the soft tissue. So these are all potential factors. And what I usually tell patients is, let's think about the risk factors that we have control over. Genetics, aging, how we age we have control over, but that process is essentially what we've got. But smoking, clearly it's a habit. Obesity is an issue. I think, one of the things that the cardiologists always talk about, quitting smoking for your heart, but as a spine clinician, we can say it can contribute directly to your quality of life right now. So that sometimes is the impetus people need to quit the habit. We still don't have, as far as I know, any data on medical marijuana, for instance, or the smoking, inhalation, vaping. My sense is that it'll be similar results, though, in terms of risks of disc-related issues. In terms of symptoms, disc herniations can actually be a variety of symptoms. As I mentioned before, pain would be the number one symptom in my mind that I see the most. But from my standpoint, we're dividing pain between limb pain or referred pain, as Karen mentioned, sciatica, versus axial spine pain, meaning pain just limited to your back, neck, or thoracic spine. So that becomes an important distinguishing characteristic of the pain. Numbness and tingling, changes to sensation, again, in similar fashion to what Karen described, as sometimes it's not associated with pain, it just can be numbness in a hand or an arm or leg. The third symptom, which becomes more and more concerning, would be weakness of one of the limbs, and we'll talk about various types of weakness. Ultimately, there may be no symptoms at all. So I have had patients that have MRIs with disc changes, but their pain has resolved or they're relatively asymptomatic. Again, signs and symptoms, signs being elicited pain or elicited findings on an exam. Symptoms are described by the patient. Always has to be correlated with imaging. And this is an area where I think a lot of people get tripped up, patients and clinicians to some extent, in that the imaging really has to correlate with the patient's experience and the pain. It's where a history still is very important, because there can be herniations that are asymptomatic, as well as a variety of other neurologic conditions that can masquerade as compressed nerve. This is really where the diagnostic portion of care is really at a premium. Interestingly, this comes up, and as we're talking online, there's now pretty substantial data showing that that spine care can be administered safely and adequately through telehealth. And I put as a caveat to a degree. Again, initial evaluations, histories, even some amount of physical can be done online. And then obviously imaging can be reviewed online. So correlating symptoms that the patient describes as well as imaging, a lot of care can be done now virtually. Ultimately, though, I still think the in-person interaction with a clinician is still paramount to the quality and level of care that's administered. And then, even though there are plenty of algorithms out there, tailoring those to the particular patient still requires human interaction, direct interaction. In terms of imaging options, I get this question quite a bit. What is adequate? What is inadequate in terms of imaging? I would consider by today's imaging standards, MRIs are considered the gold standard for diagnosing or evaluating disc-related issues or soft tissue-related issues. In my mind, an MRI is best for soft tissue. That includes the discs, the ligaments, the muscles, and the neural tissue. I do get this question quite a bit about upright MRIs, which is where a patient is actually seated as opposed to laying down in a somewhat confined area in a standard MRI. I generally, my opinion is that it's inadequate in terms of resolution to make clear diagnoses. Again, certainly for making surgical decisions, I would not just depend on an upright MRI. So that's something to consider if you have a clinician that recommends MRIs, really trying to get one in a closed or a high field open MRI would be the recommendation. X-rays, I get this question quite a bit. They're still very useful to rule out other underlying pathology. So again, if we think of the MRI as a way to evaluate soft tissue, an X-ray tells us a lot about A, the bones, B, the alignment, and if there's any dynamic changes to the spine. An example of that would be in this particular image, where the two bones of the vertebral bodies, the two bones of the spine, are not lining up perfectly. It's related to an issue at the back of the spine. But again, sometimes when a patient's laying on their backs for an MRI, these sorts of malalignments will not show up very clearly on the MRI. So they are not interchangeable. I would consider them, particularly from a surgeon standpoint, important. Both are used together. Finally, a CT scan, it can be incredibly helpful for at least early diagnosis. So before MRI, we had CAT scans, and those are somewhat useful at diagnosing overt disc herniations. They're used frequently in a trauma setting because of speed and ease of use. And then we can decide after the CT scan whether a certain portion of the spine should undergo an MRI. CT scans are also still used for more detailed bony anatomy and for preoperative planning. So that's how to keep those three straight. In terms of treatment options, as I said before, sorry, I skipped ahead. As I said before, they should be tailored to the patient, and it's really getting a very clear history and exam on the patient. I think I lost my slide there. And then really determining, is it pain, is it weakness versus numbness? And then the patient themselves. Are we dealing with a young athletic person? Are we dealing with someone who has many other medical issues that may change the treatment plan? And ultimately, that is the goal. The treatment plan should be what's best for that particular patient. Indications for immediate surgery. These are usually very straightforward for most patients. They understand that if there's sudden loss of function, so sudden loss of bowel or bladder function, saddle anesthesia, meaning in the area of their perineum or around their genitals, if they're unable to have any sensation in that area, weakness of a leg that's sudden, or an arm or a limb, I should say, are all sort of indications for urgent or more aggressive treatment, right to surgery. In terms of sudden loss of function for cervical spine issues, there are a few entities that require surgery. As I tell a lot of patients, it may be one of the few scenarios where in orthopedics or in musculoskeletal care, we are similar to, say, seeing a cardiologist, where the cardiologist says, you don't understand, you feel fine right now, but you're at high risk of having a major catastrophe. So there are cases of people with cervical stenosis, but they don't realize how many of their symptoms are related to that. Again, that's a little less common in sort of acute disc herniation scenarios. In terms of management, for the most part, for pain and numbness without weakness, typical recommendations are a minimum of 6 weeks of non-operative care. That includes medications for inflammation and spasm, physical therapy, as well as possible pain management options such as cortisone, epidural cortisone injections for temporary pain relief. Surgical options could be considered after that. And I again emphasize the majority of disc herniations do not require surgery. Current estimates, depending on the study, about 80 to 90% of patients with disc herniations will not require surgery. They either resolve their symptoms with the non-operative measures we talked about, or it just becomes asymptomatic on its own. But again, once a disc is herniated, bulging or protruding, this is again another question I get, there's no way to put that disc material back or to repair the tire or to pump the tire back up, for instance. Once there's been some degenerative change or another, we don't have that ability to turn back the clock, so to speak. And that's really where care plan should be evaluated. So once you're diagnosed with one of these entities, really starting to implement lifestyle changes that we were talking about in terms of risk factors can make a huge difference. And that's where, the professionals like Karen, as personal trainers, as physical therapists, can be very helpful in sort of keeping to those goals of a healthy lifestyle. I think at this point, I probably will just open up to questions, because I tend to find that tends to be a lot more interactive. So we're not all just sort of listening to what I have to say, but and I always learn something from the questions that I get from the audience.
Great, well, thank you. I'm going to start right from the beginning, where Padma asks, what are the chances women with bad posture will end up with a slipped disc, and how can that be avoided?
Well, that's a good question. I mean, we don't really have data in terms of the odds of that. And then bad posture, it's subject to interpretation as well. But I think we all kind of know it when we see it. I would, again, when I'm ever looking at potential risk factors, I would just in your own mind think of the risk factors that you have control over. And posture is one of those things. And it is, it's just like grandma used to say, it's really focusing on sitting up straight, shoulders back, all the basics. At least at the end of the day, if you do end up with disc-related issues, you can say to yourself, look, I think I did everything I possibly could to prevent it. And that's kind of how most of medicine works. Even in the times of the pandemic, we're really talking about risk management and reducing odds of severe illness. I think that's probably one of the misconceptions. I think a lot of lay people come into a medical office. It's not an exact science. It really depends on circumstances, and it is really about risk mitigation as opposed to, follow these 3 steps and you won't have a disc problem. I wish it were that easy. Unfortunately, it's not.
And you know how they have that saying, if you've seen one person with, then you fill in the blank. If you've seen one person with a herniated disc, you've seen one person with a herniated disc. My guess is they're all slightly different. You've showed some different views of different types of things. You've got bulging, you've got herniated, you've got ruptured. So yeah, it really is very individual too, isn't it?
Oh, absolutely. Yeah. And then, I didn't really delve into the discussion, but, there's mechanical issues, but then there's experience of pain. So again, that becomes a lot more variables to deal with. Whenever I think of, I deal with the mechanical or the sources of pain. So a disc herniation, compressing a nerve, can cause pain. But as I said, there are many patients with these sorts of things, the sort of herniations that may not be experiencing significant amount of pain or any pain at all. And that has to a variety of factors, from lifestyle to body habitus to how the message is transmitted to your brain, and then how your brain receives that information. So even weakness, pain and weakness are closely associated. So I'll often see patients with an initial flare-up who swear they can't use their legs or can't walk, but it's different than clinical weakness. That's where an exam is very important. Sometimes it can be so painful that literally your leg gives out on you, or you feel like you're going to fall the minute you stand up. And that's a different type of weakness than what we're focused on.
Got it. Okay, thank you. And you answered Jim's question about how is the condition detected. You mentioned, you talked about X-ray, and you talked about how sort of the gold standard of MRI and how, CTs can sometimes still be used. So Jim, I hope your question was answered. Olivia asks, can losing weight help alleviate a herniated disc and sciatica symptoms? And then she had asked, once the disc is herniated, it can't be reversed, which you've already answered. It can't be reversed, but could losing weight help alleviate the symptoms?
Definitely. I think that's usually the conversation we have. The surgery part of it is in some ways the straightforward part. It's the recovery process that we have to think about. So however the pain resolves, either through surgery or through other non-operative intervention, that last meeting is always very important. It's, okay, what can I do to prevent this from happening again or preserve what I have left? And that's really where, you can take control of your own health. So again, it's easier said than done. I don't think there's any magic solution to losing weight. If there is, I'm curious to hear it. But and then things like smoking cessation, being mindful. Believe it or not, I think mindfulness tends to be underappreciated in terms of risk factors. So people, often I'll hear, I was just really in a rush, or I was thinking about, wasn't even thinking about it. It was, so I was reaching down desk drawer, but I had a lot of things on my mind. I wasn't even thinking, and then something happens. So being as mindful as you can, particularly after you've had a disc herniation, again, it's do the best you can. There's no perfect formula.
Yeah, got it. That makes a lot of sense. All right, Jim asks, how about alternative treatments like acupuncture or chiropractic? What are your thoughts on those?
Oh, yeah, that's a good question. My sense is that for a true radiculopathy, for symptoms going down a leg or an arm related to a disc herniation, I don't think you're going to get, there isn't a lot of data to support chiropractic work or alternative therapies like acupuncture. If your pain is primarily axial, if it's related to just your back or your neck or your, back in particular, lower back, there is some data to show that chiropractic work, acupuncture, dry needling, which is done through physical therapy, can be helpful for myofascial pain. So, like I said, I think the biggest issue with diagnosis, and from a clinician standpoint, and I think part of our job is to be very clear about what we're treating, and then what we're not treating with a particular intervention. So, oftentimes patients will say, well, I needed a surgery, the doctor said I needed it, but may not be having radicular symptoms. So, to some extent, it has to be clear what the treatment, why you're getting a particular treatment and what its goal is in the long run.
Right, for again, for that particular individual.
Correct.
Yeah, got it. Okay. And then ironically, the next question from Mark is, any thoughts on other types of alternative therapies, such as regenerative therapies, stem cell injections, that sort of thing?
Oh yeah, no, I mean, it's certainly promising, and it's hopeful. I think the biggest issue with disc injections for stem cells, that sort of thing, actually is blood supply. It's a question I get a lot is, well, why doesn't it repair? Well, once you have a herniation, how come, you can't somehow repair? The biggest issue is actually is blood supply. So you can inject, this is the same thing with cartilage that we have in our other joints. Once you've lost the cartilage, getting it to stick, or trying to replace it and getting it to stick, is actually very difficult. So it's a blood supply issue more than it is a stem cell issue. But I definitely understand the science behind the reasoning, but I think you have to be a bit careful about promises that sound too good to be true. But there are going to be clinicians that have to kind of push science further. So I think for the right patients, if they really feel like it's worth a try, they have to understand that it may not work. But
fair enough. That makes sense. Okay. Chris says, first of all, thank you for all the great information. And Chris asks, do you have recommendations for a younger active person with chronic 18 plus months of low back disc herniation bulge that causes pain, how do you recommend evolving your PT care plan when the issue is so long standing?
Yeah, no, that is a challenge for, and I would consider a challenge for the entire healthcare team. You know, it's usually what I suggest is, you know, it'll be multimodal. You know, so depending on where the pain is, if it's primarily at the lower back, if it's chronic low back pain, the disc is part of the issue, but if it's not radicular, then there's not really a lot of surgical options to consider, and those would be a last resort. So then we start to focus on alternative therapies. I often find just trying to break the cycle of pain is very important, and that's where our pain specialists have come a long way, along with our physical therapists. So incorporating things like acupuncture, incorporating cortisone injections. I only talked about epidural cortisone injections, but there are actually a variety of other pain management techniques that are used these days by our anesthesiologists or our pain specialist colleagues that can be very helpful for at least temporarily breaking the cycle of pain. And I find that therapists and trainers can get a lot further with somebody once that happens. So it sounds like, I mean, in this situation, it may be very specific, but like I said, just trying to, you know, big picture would be try to break a cycle of inflammation or pain. Next step is then try to maintain that, you know, with the therapy exercises and everything else.
Yeah, that makes a lot of sense. And that's very encouraging for someone, a younger person with back pain, because, you know, by breaking that, that's a great suggestion and a great philosophy. And I love the way that IBJI does work together as a team, you know, working with pain management, working with physical therapists, you know, it's really, you get the whole picture for the whole person.
Yeah, and I think that's, you know, medicine is evolving. You know, there's a lot of the surgical side of things. To some extent, we've worked out a lot of it in terms of what works, what doesn't. We've fleshed out, you know, how the surgeries, you know, what types of surgeries and how we do it. It's a little more straightforward now, but really the next steps are figuring out what are the blocks to recovery. You know, and chronic pain is it's kind of like I consider it like a feedback loop. You know, there's almost like a vicious cycle where, you know, pain and mood are very closely related. It can be very challenging for someone that feels like they don't have a chance out of that.
Yeah, that makes sense. Well, good. Well, I hope your answer helped them to maybe think about ways of stopping that pain. Diane asks, what is the risk of scar tissue developing after surgery is needed?
Oh, I know that risk is that's one of the major risks of surgery. That's why we don't typically jump to surgery. Again, there's a research based on genetics more than anything else seems to be a big part of scar formation in general. And then, you know, oftentimes the physical therapist will get very involved. And it's, again, it's not a clear algorithm as to early activity versus, you know, how much activity. I always describe patients in these, especially with nerve-related or spine-related issues, I call it like a Goldilocks scenario. You know, too much will be too much, too little is too little. You kind of have to get it just right. So, you know, early range of motion for the legs and for the back is generally recommended to minimize scar tissue, but that's not a perfect formula.
Got it. And that makes sense. And again, it's sort of individual. Like you said, it's genetically how your body scars can have an impact.
Right. I think probably the mindset anybody should go into any surgery is to really appreciate that they have no other alternatives. You know, and that changes with time. You know, sometimes living with something is the best alternative.
Yeah.
And sometimes not. You know, so but also, unfortunately, we can't judge decisions in hindsight. I think it becomes a very difficult and frustrating process.
Yeah, that makes sense. It does. Yeah. All right. Cynthia asks, can a disc problem cause pain in the hips, thighs, and knees, which you've already alluded to? That's your radicular pain, right? So I'll let you just answer sort of with words that maybe will help her understand.
Yeah, no, I mean, I think maybe even I do get that question a lot, and they're very. I would consider it, well, it's like the old song, the leg bone's connected to the hip bone, blah blah blah. Yeah. They all affect each other. I definitely have patients who've had issues with an ankle or with a foot injury that can exacerbate back issues and vice versa. Yes, the short answer is yes. And then the long answer would be it really depends on the imaging, it depends on the exam. And sometimes compensations, that's often what I tell patients too, is your compensations can be their own set of problems.
Got it.
So sometimes having to be patient with the physical therapist, a lot of feedback is the important thing, I think, with that process.
Yeah, makes sense. Okay. All right. Patricia asked, is exercising at the gym okay for someone who has bulging discs?
Yes. I mean, the short answer is yes. But the caveat is, what type of exercise?
Right.
And then, what's the best alternative? And again, there's no perfect solution to that because it's about risk mitigation. There are higher risk activities or low risk activities. And the way I look at the gym is, again, this is sort of a generality, but higher efficiency. So a workout that you can get an incredible workout in 30 minutes tends to be higher risk.
Right.
A lower intensity workout for a longer period of time is lower risk. It may not give you certain benefits. It's not as efficient. You may not get sort of the euphoria of a great workout or a heavy workout. Yeah, certainly it beats the alternative, which would be sedentary. Being sedentary is probably the worst solution. So again, I would encourage people to find the right exercises, working with professionals like Karen or a physical therapist to get opinions on what type of exercises might be best suited for you. That's where there's a lot of professional training that goes into that process of developing a workout routine. So I would tend to recommend that. Obviously we want to give you the tools to take care of yourself.
Right.
But sometimes getting pointers from people with experience and have studied the topic can be a lot more efficient and a lot faster than trial and error.
Yeah, very true. Very true. Thank you.
Yeah.
All right. This was an interesting question, I thought. Laura asks, if you have one herniated disc, are you more likely to have another one?
Yeah, well, that is a good question. The short answer is yes. Technically, yes. Because the same sort of environment one disc is in, the other discs are also subject to that. Now, there are certain discs in your spine that are higher risk, just in terms of where they are, location, and force that goes across them. But the genetic process, if you're a smoker, those are kind of generalized issues. Obesity, those are all issues that will affect multiple discs. So technically, yes. I mean, which can be unsettling for a patient to hear.
Yeah.
But at the same token, you say, look, everybody has that risk, and it's living with risk is really, and managing risk is really the best way to view it. So in some ways, you're blessed if you know that you have a disc herniation, because then that's a tip off that you probably should be doing everything you can to preserve your body and maintain your health.
Huh, an interesting way to look at it. Yeah.
But I think again, that's what I usually tell patients once they're through the whole process is, okay, we don't want this to ever happen again.
Right.
you've got to say to yourself, I've done everything I possibly could to prevent it. And then at least you can, it won't be pleasant if you have another episode. It'll be discouraging, but at least you can say, look, I've done everything I possibly could within reason to protect myself.
Yeah, good, great, thank you. All right, any recommendations regarding bed pillows for optimal sleep to reduce the likelihood of recurrence of pain?
That is a $1 million question that no one has a great answer to. There isn't, because every patient's anatomy and particular situation is different. So everyone, I think, at some point in their life will have some form of back pain, but everyone has a very unique reason as to why that back pain is there.
Yeah.
So it really has to be trial and error as far as bedding, as far as pillows. There's not really a great solution to that problem, or one golden recommendation. So a lot of it is tailored to your body. That's why, for instance, a lot of these adjustable mattresses and bedding has become very popular, because for your partner, a softer bed might be what gives them a better sleep than you. At least you have more flexibility with the bedding. But it's really what gives you the best night's sleep is how we leave it.
Okay, and so is that related to comfort and just that ability to sleep?
Yeah.
Yeah.
Correct.
Okay.
Correct. Yeah. Yeah. It's that's the biggest issue, is getting a good night's sleep, which many patients with chronic pain, I mean, that's part of the contributing factor, is just needing a night of rest. Can be difficult for some patients.
Thank you. I keep getting muted. Okay. All right. Thank you. Sorry about that. All right.
No.
Yeah. Luann asks, what do you say to people who are always looking at their phones with their head bent forward? Is that something that's concerning?
It is concerning. Yeah, no, it's concerning. I think that's where medicine evolves with time. I think we're seeing a lot more issues or neck complaints, and it's a little bit of a chicken or the egg sort of question, which is, are your degenerative changes more prevalent because you're looking down all the time, or we all do that, or we're looking at computer screens, or is it just that because our necks are degenerating and we're asking our necks to be in a certain position for an extended period of time? But I think we're going to learn a lot over the next 10 to 15 years. We're already seeing certain ailments that we just didn't see as prevalent. So things related to neck pain, and then disc issues related to the neck. We're seeing a lot more complaints because of it. I know, like, my colleagues in hand surgery see a lot more thumb arthritis and or synovitis of the wrists and hands. So yeah, no, these are all lifestyle things we have to think about. And unfortunately, technology, I think, it's a love-hate relationship with a lot of technology. It's a very useful tool, but it's we can't. Lifestyle changes are required, and certainly things that you can control. I mean, if you don't have to use your phone, if you can go to a desktop computer, even this, I'm on a laptop right now. I have a lot of patients. If you go to a Starbucks and see people on their laptops, there's nobody with an upright posture. They're all hunched over. Again, that's not ideal, but you just have to kind of remind yourself to take frequent breaks.
That makes sense. Okay, thank you. Yeah, and I think it'll be interesting to see what happens for future generations who are sitting and not utilizing their bodies as much, and then also with that, kyphotic posture, it's going to be very interesting.
Yep.
All right. So another question. Let me see. We got about 6 more minutes. I thought this was an interesting question from Gina Yee. Is physical therapy something you will have to repeat throughout the course of the rest of your life?
Well, that's actually a great question. The way I would put it is, physical therapy, it's like seeing a tutor or somebody that's training you. You periodically should go back probably for tune-ups, is the way I would describe it. But ultimately, a physical therapist, trainers, they look at patients. Ultimately, you should be given the tools to do it on your own, is kind of the short answer. So physical therapy doesn't stop when you leave the therapist's office. It's really, I mean, again, it's, therapists would maybe kind of cringe at this, but from a surgeon standpoint, I'd look at therapy as your preventative medicine. It's, that is your brushing and flossing of the process. I mean, it's actually not a bad analogy. We're talking about nerve-related pain, which is a cavity or a bad toothache is, it's unrelenting. But, I'm the root canal guy in this whole thing. So it's like, well, we don't want to have a root canal. What can I do to prevent it? Therapy is your preventative, and exercise is your preventative medicine. Nutrition's also an important thing. What you put in your body, it's got to be something you have to consider. Again, that becomes more of a medical discussion, and your medical doctors, I'm sure, are just waiting to give you lots of information on that. But like tobacco, ingesting tobacco and smoking, it's going to clearly affect the rest of your body.
Yeah, that makes sense. And I might add to that, if you don't mind.
Sure.
I see a lot of patients post physical therapy, and I always say to them, what are the exercises that your physical therapist told you that you will have to do for the rest of your life? Because they often send people away with a sheaf of paper saying, do these every day or every other day or whatever. So right. I think, if you follow through and actually do those exercises, you might not have to go back and see the therapist over and over again.
That's correct, right. I mean, I think the best way to look at it is, again, it's not disparaging any one group, but I would consider like therapy teaching you how to fish as opposed to giving you fish. Sometimes pain, certain pain management things, and then chiropractic work, I tend to find to be more about getting you out of trouble, as opposed to how do we break the cycle.
Great, thank you. All right.
Yep.
Mona asks, why are steroid injections only given at specific times? And I think that probably means like at intervals, certain intervals, that type of thing is my guess. Not time of day, but No,
you're right. Yeah, I'm just trying to think of decision making. I don't know if there are hard and fast rules about cortisone injections, other than there's technically risk anytime something from the outside is going into your body. So there's, even though it's very minute, there's risk of infection, there's risk of, again, dosage of steroid. It's a medication going into your body. Plus, not all injections are immediate relief. So I know a lot of pain specialists will recommend, for instance, waiting at least 2 weeks before considering a second injection, because there are definitely patients that don't feel like they got any relief, and then a week and a half into it, they're suddenly snap, it kicks in. So you don't want to kind of, I think there's, that's the other observation I would have. Sometimes, time is a variable. Sometimes doing nothing is doing something, which is just waiting. There's always a tendency, and I would be the same way. What can I do to make myself better, or how can I speed up this process? And that's where, as clinicians, we have to say, look, we've been through this. Patience is part of it. It will get better. And if it doesn't, we know what to do if it doesn't.
Got it. Thank you. That was helpful. I'm as you're answering, I'm looking at the next few questions because we only have 1 minute left.
Oh shoot.
So
okay.
I don't want to ask something that's super long. So I apologize to those of you who asked questions that were super long. I'm probably not going to be able to get to those. How about, can you give us a recommendation for something that people can do prevention-wise if you think, oh, I'm starting to have a little bit of something happening, what can I do to keep myself as safe and healthy as I can? Maybe do we just go back to that slide that says, hey, Quit smoking, lose weight, eat right, exercise.
Yeah, no, I think that is the difficulty with the human condition. You know, some pains are very transient. You know, they can be very severe, but then they go away. I mean, I frequently have patients who say, well, in the mornings I wake up, I'm as stiff as could be, but an hour or two in, I'm fine. Generally speaking, pains that come and go, I'm less worried about. Pains that are more persistent or escalating, then we have to do something. But I think in terms of prevention, I think, you know, if you can get yourself into a routine, you know, like brushing your teeth for 15 to 20 minutes. And I think the other thing I always is, let's not be as hard on ourselves as we are. You know, when it comes to exercise, half measures are better than no measures. You know, so if you can get 15 to 20 minutes of something in, I'd rather have you do that than nothing, and then just say, forget it, I can't. You know, that happens sometimes too with therapy. They'll give you a whole packet of stuff, and it can be overwhelming. It's just like, there's no way, I don't have time to do, you know, these 50 exercises or whatever. You know, if you can get it to 15 to 20 minutes, that's better than nothing. And just being mindful of all the things that you have control over, as opposed to what you don't have control over.
That was a perfect ending. Thank you so much, Dr.
Sure.
Erulkar. For those of you who have
my
further
pleasure.
questions, you can reach out to Dr. Erulkar. His information's on the screen now. It was really fantastic. Thank you for all the great information. Thank you to everyone who was watching tonight. Thank you for all your questions. And thank you for your very insightful and thoughtful answers, Dr. Erulkar.
My pleasure. Thanks so much, Karen. Thanks for having me.
Have a great night, everybody. Thank you.
Bye-bye.
Bye-bye.